Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Center in New York City. My name is Pedro Moreno, and I will be your moderator today. We would love to hear from you, so please send us your questions directly from the website or on YouTube. And remember, all our previous Structural Heart Life Cases are there for your review in our website at ccclivecases.org. And now let me transfer you to the cath lab for a very interesting case.
All right. Good morning, Pedro, and viewers of our CCC live cases, the structural section. We all are here. Myself, then Dr. Gilbert Tang, our surgical colleague, Dr. Keeney, Dr. Sahil Khera on the left side, and then we have Dr. Lucy Safi, echocardiographer. Then we have two fellows here, Maria Elena and Pratish. So all and rest of the staff in here, along with our chief anesthesiologist, all making this case successful. Very interesting. If we can show the slide point of view, that as you can see the faculty involved, and anesthesiologist is Casey Drubin. So this patient is the Evoque TTVR in a patient with recurrent heart failure and high surgical risk. We selected the Evoque because few cases which we have shown, they have very nice, our web hits of 5,000 plus on these cases. So we selected to do a Evoque TTVR, and we'll go step by step. This is our episode number 81 on an 87-year-old female who showed worsening dyspnea and dizziness, heart failure admission, admitted recently, IV diuretic, has done fine since then, has a severe TR for last 2-3 years, advised to get intervention but declined in the past, but continues to be recurrent heart failure, so decided now. As far as medical therapy is concerned, on optimal medical therapy, and as you can see there, patient has electrocardiogram is a sinus rhythm, and normal coronary right heart pressures were mildly elevated, and of course we'll go with the echo, which showed severe valvular tricuspid regurgitation with a mixed etiology, Myxomatous valve with annular dilatation, which is more atrial, and then large coaptation gap, dilated RA and RV with mildly reduced RV function. Mild MR, aortic sclerosis without any gradient, LVEF 45%. So that basically tells you that in this particular case, its predominant pathology is the tricuspid regurgitation. And now Lucy Safi can show us live. This is the recorded, but now we can show the live what is going on now. Go to the live. Yeah, Lucy.
Thank you, Dr. Sharma. So this is interprocedural TEE. You can see in our 4-chamber view that she has biatrial enlargement. The LVEF is mildly reduced. The RVEF actually calculates normal, which I'll show you in just a moment. No obvious pericardial effusion in this view. The tricuspid regurgitation, you can see here it's a wide base jet. This patient was prehabbed and diuresed prior to coming in here. And the majority of the regurgitation is centrally through the Myxomatous valve. The leaflets here you can see are billowing, consistent with my tricuspid valve prolapse, and likely the etiology of primary TR for this particular patient. RVSP was mildly increased with the peak velocity around 3. The mean gradient across the tricuspid valve was 0, as you can see. And then here is our PISA. Our PISA actually calculates with an ERO of 0.65, which is in the massive range with a volume in the severe range of about 42. And on our transgastric imaging here, you can see again the Myxomatous billowy leaflets, anterior lateral papillary muscle is where my biplane is here, more on the anterior side with the redundant, again, tricuspid valve leaflets. The TAPSE measured 18, which is within normal limits for RV systolic function. The S prime also within normal limits, about 10.3. And we did an RV strain, which free wall strain was negative 27, again, all within normal limits. The calculated PA-RV coupling was 0.5, again, consistent with normal function. We did get some views of the other valves. There's only mild MR and mild AR, and no clot in the appendage. We got some baseline ICE images as well. I can show you those quickly. Here again is the Myxomatous tricuspid valve on ICE imaging with the severe TR and then X-plane through the valve, and our 3D here. The valve did confirm measurement, 48 millimeter Evoque valve. Thank you.
Okay. So from your point of view, is there tethering of the valve leaflets or at all, or just to
It's primary TR.
primary?
Yep.
And the coaptation gap? Remember, that question will always come. What is the limit allowed for your coaptation gap in the Evoque versus TTVR? I mean, the M tier, sorry, T tier. And the secondly is we'll ask our experts here that is there any contraindication of doing the TTVR versus repair, just putting the clip, tricuspid clip, based on the RV dysfunction, if there is a severe RV dysfunction, or is there a limit for the pulmonary hypertension? Both Gilbert and Sahil?
Sure, I can take that question. So this case is actually very good for both T-tier as well as TTVR. So you don't have much of a malcoaptation. The patient has been diuresed and optimized for last couple of days. With a bicuspid, it's a functional bicuspid tricuspid valve, if you see, and it's a primary TR. So you can do both. The issue is that with such wide jets, I think you get complete resolution of tricuspid leak, especially when the RV function is so well preserved with TTVR. That's why we chose TTVR. The only contraindications for not doing TTVR in these cases, if you have severe pulmonary hypertension, if you have severe RV dysfunction, or if you have any contraindication to anticoagulation.
All right.
Yeah, so I would add that, now the literature has emerged that moderate TR is no longer acceptable because, what happens, patient get discharged, they, change the diuretic dose, they're not optimized medically, and then they come back with worse than moderate, so which is obviously has now an implication on clinical outcomes. So now we aim for mild or less TR with T-tier. If you're not able to accomplish that, we're one of the first triluminate sites, so we have a lot of experience here. Then we think that replacement would be a better alternative, as long as what Sahil mentioned in terms of some of the red flags that we need to identify.
Now, I'll show some of the data. So what was in the triluminate, because many of the trials have shown the moderate TR after the triclip is almost 50%.
Yes.
What was the data?
Yeah, so basically, if you recall the triluminate randomized trial, so even though there's 80% or fewer patients with moderate or less TR, only about 45% were mild or less TR. And we know that the more residual TR you have, the less KCCQ improvement that you get, so which makes sense. So I think now, given both platforms are commercial and there's been a lot of experience both in the US and Europe, I think people are now starting to appreciate that just like mitral, the less tricuspid leak you get afterwards, the better the patient will be.
Beautiful. So that actually one of the region that the whole field is evolving towards more. If you can do a replacement, is preferred, and there are some criteria which I'll go over a little later. So we already have gone through this. Now, this is a 3D, nice color pictures, which is just now CTA. Who wants to say anything?
Yeah, so I'll start with this. So we do a preliminary screen. Each device is manufacturer specific and design specific. So the manufacturer did a very in-depth analysis. But this is kind of our initial screen in terms of annular sizing. They have a sizing range up to 56 millimeter valve. The smallest is 44. So if this patient, for example, screen out for Evoque, TTVR, we would have two options. Either commercially, we can treat with T-tier with maybe a not so ideal result, if there's no other since there's no other FDA-approved option. Or now we have other emerging transcatheter tricuspid replacement device that Lucy and Sahil can mention later on as a part of the trial. So these are really two options. And so this is kind of a quick screen that we do at our own center. Next slide. And you can see again, this is from now the Edwards Life Sciences. You can see in terms of the oversizing and also both, not just the annulus and systole and diastole, but remember, unlike the mitral, in the tricuspid space, the diastole is what gets bigger. So don't size by systole. You're going to be misled. We've done it before ourselves, and so the diastole is the key in terms of looking at that. So you can see here in diastole is only 2% oversized, and systole is 7% oversized. So this is a sweet range. You don't need to oversize so much. This is not the mitral. The risk of migration later on is very low because it's a venous state. But you also need to look at the basal RV oversize because remember, the valve sits a bit into the right ventricle. So if you don't have that space to accommodate that, you can actually risk of embolization atrially. So these are some of the things that the Edwards team look at. You can see some of the implant angle that they've identified. Next slide, Dr. Sharma. And then these are just some of the red flags. So on the right side, the boxes are looking at is the atrial height. So you need to have enough height to be able to clear. Otherwise, if the valve is too ventricular, you cannot deploy. So in that case, you might need to go from left groin, which allows you to gain some height. So in this case, you can see in systole and diastole, it was shown as green, so that means it's favorable. And also the RV depth is important in the mitral tricuspid space. If you don't have enough depth, you're not going to be able to clear the delivery catheter. So you're going to be too atrial. Now this system is very nice, and Sahil and Dr. Kini later on will show how you can change the depth of the platform, but not all devices are like that. So you need to understand your own device that you plan to use, and obviously the company manufacturer are excellent in working these cases. They have thousands of cases experience. Next slide.
Beautiful. Okay. So basically summary is 87-year-old patient with the mixed severe tricuspid regurgitation. Is ready for the TTVR using 48 millimeter Evoque valve, which will be about 2%, 2% oversize, and so using the right percutaneous femoral vein or left.
Right today. So yeah, just a couple of points while there's setting up here. So Evoque works by radial strength anchor, but also the leaflet capture. Not all devices are like that. The Intrepid, for example, relies on annular anchoring. There's no feet to capture a leaflet. So it's very important to understand the device mechanism of anchor fixation so that, when you screen the patient, when you do the procedure, you have things to look for.
Okay, let's go fluoro.
Yep.
Yeah, you're live on fluoro.
Yeah. Okay.
Tell us what are you doing now?
Can we show echo live, please? Sorry, 1 second.
Can we go fluoro live?
No, we need to show echo live for the audience because you need to see where.
Good.
Okay, Lucy, let's check position.
Yep, checking
There's
now.
not much RV depth. So what we're trying to do here is using an Agilis catheter, trying to put a safari wire across the tricuspid valve into the RV apex.
You can go in deeper, I think, You're a little anterior. And you're at
Little
the
anterior, you
you're
think?
at the you're at the level of the, if you can go inferior to this PAP here, yeah.
Try now.
That's
Do we
better.
do this way or you want to use
Can you
pigtail
get it
and do it?
further in? More inferior?
This is the safest way to... Actually, Lucy, I like it there.
Okay.
Because remember, there's not much RV depth. Can we dim the lights?
Yeah.
Now we can dim the light.
Lucy, I think we'll be okay here.
Okay.
Now hold on. What
I think-
is the show? Can you see it on the echo there? Yeah.
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 Good. Good.
So Lucy, can you explain to the audience what view we're looking at,
Yes.
to look at the wire position?
The wire positioning here is, we like to do it in the transgastric view, in the RV long axis view.
Don't give any yet.
And you want the wire to be positioned in the inferior aspect of the RV at the RV apex. This particular patient doesn't have a very deep RV, so you see that it's curling, and the curl of the wire is coming up towards the tricuspid valve leaflet. So, the best position is just not in the RVOT. You want it
4x4.
more inferior. So that's essentially where the wire is.
Damien.
All right. Okay, so wire is in good position. What is the next step?
So next, the sheet. 1 second. Okay, let me take the floor. Sorry. So we'll take the dilator out, and then give me the 28 French and the 33 French. So we'll do serial dilatations here before we get the device across. Pin the wire.
Dilatation of the femoral vein.
Femoral vein, correct?
Yes. Come.
Quickly. Yeah.
Come here. Send the fellow.
I got it.
Hold. Keep holding.
Okay, give me 33 next.
Press hard.
Device is ready.
So we're dilating femoral
Yes.
vein.
28 French and then 33 French.
You see the wire still good? Looks like a little posterior. Huh?
I can recheck.
Why don't you explain all those views now?
Yeah.
Echo
So
views.
we're in right aerial projection.
That's good.
So you can see the wire. Those all mitral tricuspid work is done in aerial projection to elongate the ventricle, and so you can see, this particular patient doesn't have a lot of other landmarks, but you can fluoroscopically often see like a RCA stance or a calcification. That's the atrioventricular groove. That's where the mitral tricuspid valve is located typically, and also, of course, if you have other devices in place, that it will be easier to see, like prosthetic mitral valve, or even like an annuloplasty ring, for example. So those are options that you can see fluoroscopically to help you with the guidance.
Pin the wire? Yeah. Yeah. Okay,
Question number
going-
2. Okay.
Going into the valve. Go ahead. So there's some scoliosis you can see there. Should go in pretty smoothly. It's a hydrophilic system. Keep going. Good. Stop here. Stop here. Yeah. So now we're going to pull the sheath back because without that you won't be able to flex the system. Don't push wire. Gilbert, come in front.
Can you show the knobs? Show the knobs.
1 second.
So it seems like the wire's,
Yeah, the wire has changed position.
yeah, it's curled up into the valvula.
So stay there. I'm just trying to get this. The flex is not moving. Go ahead. Yeah, don't have any runway here. Okay, now try here, Gilbert. Okay, stay here. So we're going to try to flex and try now. Okay.
Can you show us the wire, please, Lucy?
Yeah, do you want it in a transgastric or?
Go back to transgastric.
Now
and show
it
us the
looks
wire.
better the way the wire is. Yeah.
You know what? I think it's straddling in the RA. Sometimes it happens. Go ahead. Try now. And just stay here.
It's very
stay
high.
here. Stay here. Stay here. Okay.
Pull the wire back a little bit.
Stay here.
Yeah,
No.
see, it's curled really inferior.
Inferior, right?
Yes.
Okay. Take the system out. Give me the sheath again. We're going to switch the wire again. We'll try to rewire. Good. Regular sheath. Core sheath, please.
They want a sheath for
Yeah.
the vein.
I got wire.
Good. Flush the system.
So the wire is inferior, right? The position. You
Yes.
can see that it's
Challenge with the shallow.
with
Pick it up.
smaller RV.
Yeah. Okay. Let's refix this.
Anesthesia, you can give 250 more fluid, please. So this is very important in terms of
Now the
RV
other question
conditioning.
is, should we think about switching the side to left?
Yeah, I would go left.
Huh? We may have to go left here, so. Okay. Right. Okay, Agilis next.
I would go left, I think.
Yeah,
I think we should go left.
Left
Let's go
what,
do it
femoral
like
vein?
this. Yes.
I think we may have to go
Yeah,
left
I
here.
think I would not
Because-
try this. I would just switch to left femoral right now
Okay,
because
so keep this here.
I don't think you have. If you look at the
Yeah, we won't
long
have much
axis,
runway.
you don't have a lot of one way. So
Okay. Give me a gore sheath for the left. Keep this.
I'm going to take this out, right? We don't.
No, leave it
Okay.
there. Leave it there. We can pull the suture. Pull the
No,
suture.
I'm talking about a wire.
Yeah. Pull
The
one
wire?
suture.
Yeah.
No, pull this suture. So it tacks the hole. Pull the venous suture. Here. Good. Now
So
lock it.
Gilbert, explain to
Yeah.
us the rationale for the switching axes now.
I think we need more height here.
Yeah,
There's not much height because the RV is really shallow. So the left side will give us more height to get into the valve.
Could we have
That's okay. Leave it.
analyze this on the CT?
They do, but remember the RV changes. It's very dynamic, right? That's why we have echo to see in real time to make the decision. Because sometimes you think on CT. Remember, the CT scan was done, at least months or weeks ago, right? If not longer. Patient's anatomy and physiology has changed in the
Disconnecting
interim.
lines.
Sometimes
Anesthesia.
that's why we always use echo to make sure that we have.
No, it
The-
looks better, no? Trajectory there,
the-
no?
It may not curve.
No?
What we need to look for is that, for example, if this were a 56 valve, you have to diurese and optimize the anatomy, because if it gets bigger, then you don't have a valve size that can be commercially treated. In a 44 and 48, you don't want to diurese so much because you don't want to shrink, and then you have no anatomy to work with, and the valve is too oversized. So we had a case before where we actually had that situation, and the patient ended up actually getting a T-tier instead because the anatomy is too small for even the 44 valve. So this is why we always confirm an echo in terms of the annular measurement and also the size measurement. We actually, in fact, in this case, have increased, our preload. Remember, the right ventricle is very preload dependent. So we need to make sure that we have enough runway, and that's what we were talking about earlier in terms of predicting on CT, but also on echo as well, to make sure that we have no issue in terms of the clearance. Because once the valve anchors are exposed, you're committed, and if it's too ventricular, it's gonna be, you will not be able to deploy the valve. And if you're more atrial, it's okay because the Evoque system has a depth knob that you can actually descend into the RV, but there's no knob to go more atrial. So this is something that is very critical to understand.
Okay, take a ProGlide next.
SS, you have to do the slides. They screwed up.
Okay, take a ProGlide next. So yeah, I think the decision to switch early on is always a good one.
Yeah.
We could have tried again, but what we have seen is sometimes just switching is the easiest thing to do. And there is some IVC offset if you look at the CT scan.
So usually in the trials, what would be the incidence of having to switch?
I mean, that was not part of this reported, right? It was not reported in the study, but certainly, I think it happens definitely commercially. So.
Just give me the sheet, please. We can do this can wait. The sheet, please.
And that is happening because of the?
I think the RV is small. So the RV depth, remember we talked about that in systole is only on 42 and change. So, the patient's volume status change. That's why we were just telling the audience that if it's a large valve, 52, 56, you have to diurese and optimize, because if it gets bigger, you cannot treat. Smaller valve is the opposite. You don't want to give a little more volume, actually, in fact, because if the patient is dry and the RV is shrunk, you might not actually have enough space to work with, or the valve is too oversized, which we had one case that we had to end up doing T-tier instead. So because the valve is even the smallest valve is too big for the anatomy.
And still the same valve can be used, right?
Yes.
Yes.
Okay, so what we can do is, while they're putting the left side, do you want me to present some slides?
You can present some slides.
Yeah, present some slides.
So let's go to the slide presentation, please. So Pedro, we are going to do, while they're getting things ready on the
Big switcher for me,
left
please.
sheets and so, we are going to do our presentation now. So this basically was summary. So what I'm going to talk about,
not there.
the recent publication, the TTVR field. Everybody should be low voice, please. One is the TRISCEND 2 trial. Data were just presented in ACC for 2 years result. Then TTVR outcomes with the TVT results at 30 days in the real world data. And then third one, little bit on the TriLuminate trial, which we have shown earlier also, outcomes at 2 years. As you know, various devices, whether S2 has repair, valve replacement, annuloplasty, and other cable implant, gap filling devices, and one of the TriFlow, which we're going to show a little later. So a lot of work being done in the tricuspid in various aspects, and two of them, as we know, had made to the finish line, which is the TriClip as well as the Evoque. So we have two dedicated devices for the left side. For the right side, while we have nothing for the left yet, as you know, the mitral position. So things are going good. So of that, the MTR and basically the TTVR after the trials where we use it, and all those cases ongoing. The various valves which are shown here, but let's go to this. The lot of data on the Evoque. Evoque after the initial data, then of course the randomized trial. That is what I'm going to show here. So question is, when patient with a severe TR comes, what do we do? Clearly, we have to assess the patient in terms of the risk after initial evaluation. Yeah. Yeah. So initial, after evaluation, then we decide the patient risk, whether patient needs surgery or what patient will need. So this basically is that if patients are low risk, good surgical risk, should go for surgical valve replacement and or repair. And therefore, if the patient at the high surgical risk, then we decide basically on various aspects. Basically is whether it's a pacemaker lead causing the issue, server, and then the patient, how is your RV function, and many other factors, the bleeding risk, and so on and so forth. We decide that if those risks are reasonable, you want to do TTVR. So ideally, it should be, our default approach has to be TTVR. It has associated slightly higher complication, but this eliminates the tricuspid regurgitation. But if you cannot do those, then we go with the repair, which is the TTR, that basically is. So this actually is a very nice slide, taken from repair on the left side to the replacement on the right side, surgical, and of course the TTR and TTVR shown here. So where do you use the TTR? Basically, a small gap. And this particular case had a more than 7 millimeter gap. So 7 to 8.5, go to your TTR, and of course, if you have the less gap, then of course you go down to TTR. Otherwise, sorry, you go to the MT, basically the valve replacement what we have. And same, the multiple leaflets and the pacemaker, which we call the IED lead, basically that conduction abnormality. So those cases should be done with the basically with a tricuspid valve replacement. And then echocardiographic, you have to have a good echocardiogram for these. Now, if their patients are extreme, as on the right side, then those patients have to go for the surgical replacement as seen here. Okay, with that note, there is another algorithm comes that based on the echocardiogram, that good echocardiogram, and we have the criteria they call the glide score. And glide score based on the various factors shown there, if your glide score is low, glide score is medium, or glide score is high. So basically is that once it is low, that you try to go for the TTR, and if glide score is high, which is the clinical and CT assessment for the TTVR suitability. If it's good, then you go to TTVR. If not good, then in those cases you go for the TTR. Reason basically is, and this is a very nice diagram showing the challenges and how we take care of those, because this will require adequate management of the pre and post these cases. And the one we are using is the TriScent 2 trial Evoque. And as I mentioned earlier, there's not only the valve, as you see the side, so basically anchors on the valve, and it's available in 44, 48, 52, and 56, and basically comes with a 28 French outer diameter, and more, actually 56 is allowed to now encroach on the more valve areas and also. So with that note, so key is the TriScent 2 trial was the patient, 400 patients were enrolled in the TTVR or in the control group with a 2 to 1 fashion. So 300 versus 100 followed for 1 year and then 2 years. So initially 1 year data were very clear that their better quality of life eliminated the TR completely, but there was no difference in hospitalization or in mortality. So this is basically was the data as you can see here. And of course, there was higher bleeding, which expect with the valve replacement compared to control and higher need for pacemaker. And they all are related to part of the TTVR. So very important, the TTVR, while very good to eliminate the tricuspid regurgitation, but was associated with more bleeding because requiring oral anticoagulation and of course the bigger sheath size and same thing exercise issues. And the secondly is the pacemaker rate about 17 to 20%. So then now they presented the data of 2 year Turani in ACC 20. These are the cases which the TTVR severity at the baseline was identical they have various new definitions. We call data in terms of the modified intention to treat. What happened is that patients in the TTVR group, after 1 year, they were allowed to cross over if remain symptomatic in the medical therapy group. So optimum medical therapy group. So therefore, it becomes a little more complex. At 2 years, how do you follow them? If you're there 20, 30%, you have crossover. So clearly your benefit of the Evoque on the long run will be affected. So anyways, and then with the safety point of view and the TR grade, these were the data. Now, what we learned, basically, the modified intention to treat outcome in terms of the all-cause mortality or heart failure hospitalization was identical between two strategies, as you can see there, right? Now, if you take a pure one, the TTVR without any crossover, then you can see there is a big difference in favor of the TTVR compared to control without crossover. Now, once you did a crossover, which is in the bottom green line, that after 1 year, the outcome of the patients who got the TTVR after 1 year it was exactly identical to the original TTVR cases. Similar data we had for the mitral clip. Same thing, that once you randomize, there was 2 years, here was 1 year. So outcome remained the same, similar, as you can see here. But these are the all-cause mortality, individual point and heart failure hospitalization. As you can there, it's a crossover. Once you take a crossover out, then you clear-cut benefit. You have crossover in, then it's little less. But overall showing that the outcomes were better in the TTVR group compared to control group. And with the optimum medical therapy group. So this is put together here. Now here you have taken patients, including crossover in the control group, as you saw, and basically showed that overall, although trend of was lower in the TTVR group, but was not associated with significant difference. But only difference was that you have a higher need for pacemaker, which we knew was 17% in the trial. But the biggest difference is here, which is the tricuspid regurgitation grade. As you can see here, TTVR eliminated your more than mild tricuspid regurg. So 95% of patients had less than mild TR. So that's a great data. Second, if you have a medical therapy only, the patients who have a less than mild TR was only 15%. Now, after 1 year, we have a crossover. So then it still became the same, that after crossover 2 year, 95% patient had a mild TR. So basically showing that nothing harm. You start with a control group, then you made a TTVR after 1 year, and you follow them accordingly. Then second point basically was the KCCQ score. You can see significant improvement. Higher the number, better it is. You can see that medical therapy also has a little improvement, but significant improvement occurred in patients' KCCQ score in patients with who received the TTVR. Now, then post-hoc analysis, they say that clearly taking some Bayesian multiple imputation, because we knowing that crossover really created trouble, but this is the data of, if let's say if would not have crossed, but they have imputed control, that in terms of the all-cause mortality, hospitalization, definitely, as well as KCCQ score favored the TTVR. So basically conclusion was that at 2 years, the TTVR was very effective. Less than 5% had a mild TR. More important point, they have improved quality of life. They have, yes, higher bleeding and pacemaker, that we need to know. And then once you crossed over, in the control group, outcome was similar. And then the basically is that safety procedure was generally safe, although had a 70% permanent pacemaker and so. Now this is the trial. Now you say, well, what happened in the real life? And this is the data from TVT registry. Two of our investigators of Gilbert and Sahil is the part of this publication by Raj Makkar in the JAMA Cardiology. These are data of the TVT registry, and say take the 30-day endpoints. The 30-day, of course, these patients are sick, both primary as well as secondary, half and half, in terms of the tricuspid regurgitation, and you see the outcome. Outcomes clearly are much better than what was in the trial. You see the all-cause mortality, 3%, and of course, the recurrent hospitalization, all in terms of patient who developing other new pacemaker. Pacemaker rate is 15%. Remember in the trial was 18, 19%. Bleeding is 7%. And of course, the vascular interventions, and so as shown in this study, that overall numbers are there, but it seems to be in real world, actually your event rate is lower than what was in the trial. So many times what happens is trial have very selective cases and the event rate is clearly lower in the trial, but here in the real world, also event rate was lower. So you can say that done correctly with good teaching and control, that your event rate will be lower in the actual TTVR in the real life. And that basically, and then of course, effectiveness is there that eliminated the tricuspid regurgitation completely in these patients and has done a tremendous job. Same thing for the NYHA class, very little patient in the class 1, class 3 or 4, and improvement in the KCCQ score occurred. So just to say that whatever happened in the randomized trial, we as an investigator learned quite a bit. The event rate is much lower than what was in the trial, and with the patient even with a more comorbid condition. So conclusion was the early US real world experience with TTVR confirms safety and effectiveness in patients with severe TR. 30-day outcomes are consistent with the TRISCEND 2 pivotal trial, demonstrating acceptable safety, near complete TR elimination, and significant health status improvement in older comorbid population. Rate of new our electrical pacemaker and implantation and bleeding were lower than randomized clinical trial experience. So this was very reassuring. Then we have few other publications from Canadian, basically about the TTVR showing the same message, that improvement is there in the KCCQ, a 6-minute walk test, and of course, mortality was 6.7%, pacemaker rate was about 16%. There's another study from Asia Pacific, particularly China, comparing TTR with the TTVR. Few things became very clear, that as you can see, moderate plus tricuspid rigors remain about 50% of cases in the TTR. In the TTVR, only 5% have the mild, more than mild tricuspid regurgitation. Now, big information, as you can see here, that in terms of 30-day New York class, the majority of these patients in the TTVR group were in the class 1 and 2, 93.7, and it was 96% in the TTR group. The also length of stay was much higher in the TTVR group, as you can see there, and of course there was some difference in the platelet count. So it seems to be that TTVR effective, but also associated with a little higher bleeding, and more importantly, increased length of stay in this study. So then there is another study which compared the H2 as repair with the TTVR and basically showed the similar message. TTR, less complication, safety-wise a little better compared to TTVR, but at the same time in elimination of the regurgitation, it is less effective. So this is what we need to all understand, and we have to see that what we need to do based on the patient need as shown up to the 12-month data. So, and then lastly, just a few words about the triluminate, which we have shown it before, published last year in Circulation, and Gilbert Tang, one of the senior author on this, with a 2-year outcome, and basically showed that after 2 years, then patient went, in the control group, they went into the intervention. So clearly the difference occurred because of the tricuspid valve intervention. Otherwise, mortality and tricuspid valve surgery were identical in the both groups, but intervention became higher in the control because after 2 years, the patients could go receive the tricuspid triclip. Now, same way, it showed that overall, as you can see here, that moderate tricuspid regurgitation, you can see about 40+% of cases, 40 to 50. And in the control group, that number is only 20%. But those who cross over after 2 years, look at the number, same, 40+%. So very interesting. So there is a new device. This actually one of our fellows is involved in that, TriFlow, which is a null tricuspid optimizer for severe tricuspid regurg, and they say it could be done in the large orifice also. Is a tripod. Then in the center, the valve is inserted and it stays there. They did 4 cases. They showed the data. Actually, now they are apparently 10. Fixated, there are no complication, ease of use, and 100% procedural success with no device time trouble. In the past, procedure time was much higher. Now it has gone down to 1/3 of that. So that basically, the TriFlow device, I don't think it's going further. They are waiting for some financial help to get to this trial, bring this trial device to the trial, and so. So with that note, I'll stop here because we are ready here. All right. Our team, tell us, everybody,
Dr.
what we are.
Sharma, we have a question from the audience.
Yes.
It's Dr. Saeed. He's asking, does TTVR increases survival?
Yeah, so actually, if you saw that data, that if you take in the TRISCEND 2 trial, at 2 years, if you take those who received only TTVR and you compare against control, answer is yes. Both, but did not show at 1 year, but 2 years. It took them 2 years that to show benefit. And same thing in the triluminate, decreased heart failure occurred after 2 years. So key is answer that the TTVR at 2 years shows improvement, shows low, improvement in mortality compared to control. Only problem in the TRISCEND that almost half of those patients were after 1 year. They were allowed to get the TTVR. Yeah.
Got it.
Okay, now let's see what they are now. They're basically going through the left-sided puncture and the valve in, the wire is there. Keep talking, guys. Tell us what you're doing now.
Very hard to get this across.
We don't hear you.
The wire's on the apex.
Oh, now it's good.
Yeah.
Yeah, it's the issue is we don't have any runway. Go ahead.
But why are you not
Pull back
having
the
any
sheet.
runway?
It's the small, if you see, Dr. Sharma, the RV, go ahead, gentle push.
RV small.
So now stay there, stay there.
Or you can go with a stiffer wire also sometimes, right?
No.
This is a stiff wire. Yeah, go.
No means...
Go. So I'm jiggling slowly, but it's very, just stay there. Stay there. Stay there, stay there, don't do anything. Yeah, stay there, stay there, stay there. All right. So jiggle push, a little trick here. Wow. Okay, back to
Let's bring this to the other
programming
side.
now. Move this back.
Yeah, we need to move this back a lot.
Very anterior position.
Move this back more.
Now tell us what is the right position based on the TE.
Good.
Okay, good.
So
Well,
on T,
the
you
ice
would
is
want,
out. You want to put the ice back up?
Not yet.
Not yet, Dr.
Okay,
Okay,
so
Lucy, let's go.
very
so your
difficult to get this
anterior
across.
position with anterior trajectory.
Anterior trajectory, okay, we'll fix
Anterior
it.
position, anterior trajectory.
Looks a little septal bias, right?
Yes.
LS?
Yes.
We'll fix it.
Yeah, good.
Okay, looks good. Remove
No,
the
but you have
parallax.
to describe the knobs a little bit.
Yeah. So
Okay.
can
Go
we
ahead,
go to, can we show this
The
here?
ceiling. We have the ceiling, yeah.
So you saw we switched from the right to the left axis, still very hard to get across because there was not much depth and there was a massive IVC offset with a small RV.
That one? Okay.
So we used a lot of primary flex. You see this light gray, that's the primary flex. It's basically brings you anterior posterior, also flexes the system. Then you have the dark gray, which is your secondary flex. It moves septal lateral. Then you have your depth knob, which is the third one, the black here. And then you have the retractor, which is anterior posterior as you go forward and backward. So these are the four things for your movements and maneuvers. And for the valve release, you have the white and the blue. The white is for your ventricular release, and the blue is for your atrial and final release.
So should we do a timeout, or you want to expose the capsule first?
We can do timeout. Looks good actually here.
Let's go capsule.
So you can see the
So
trajectory.
as soon
Lucy, you
as,
can talk about the trajectory here.
Yeah, so I labeled the screen for you, posterior here, anterior here, septal here, and lateral here. I'll try to keep that same orientation the whole case. You can see that this is your catheter. It's positioned centrally in the P and A with a slight anterior trajectory. And then also in the SL, it's positioned centrally with a slight septal trajectory.
So it looks pretty good, right?
Yeah, I think the coaxiality is quite good in terms of trajectory. PASL, right? Agree,
Yes.
Lucy?
Yes, Gilbert, I agree.
Yeah, I think we can start.
So I'm going to expose the anchors a little bit.
To see.
We can do a quick timeout here.
Yep. Timeout, please.
Use some more depth.
Okay, Danessa, so flush
Can
bus at
someone
3 o'clock.
explain what you're
So
showing
yeah,
on
so
the
what we're
echo?
saying is that we want to know where the position is before we start deploying so we can actually remember what they are. So the flush part at 3 o'clock, just in terms of looking, in case when we do a lot of manipulation, the primary flex at 2, secondary flex is at 1, and the depth is at 1, and then the cradle it's around 60-40. So this is a kind of default position. Every case is different, but you need to have the team write down so we can go back to it in case we get ourselves out of trouble. Go ahead.
Okay, looks good. You show the anchors. So we've exposed the feet of the anchors. You can see it on echo. Lucy can talk about it. It's just 1 millimeter below the annulus. I would like to add a little more depth here, if that's okay. Lucy, what do you think?
Yes, I would add just a little bit
Here,
more.
much better now. You see it? So added a little depth.
These are very Myxomatous
And
reflex,
see that
so we
our
want to make
top
sure
camera actually was
we're
designed
below.
by NYHA and with the broadband
I may have to
AV.
rebuild, yeah.
Such a nice demonstration and visualization of the process active.
Lucy, can you talk about the anchors here, what you're looking at?
Yes, so in the P&A, I see them fairly clearly. So these are your anchors here. I'm going to try to keep my blue line right at the anchors. Here on the SNL, we have...
Yeah, much better now. I centralized it. You see that?
Yeah, we're favoring still on the lateral side. I may have to rebuild my MPR unless you're okay with it. I think you're favoring septal.
Here.
Yeah, it's a little lateral bias. I think we can, maybe even clock a little bit to go more septal. Good.
Yep.
Remember, it's primary TR, right? So there's a lot of leaflet. Leaflet is not the issue. You
Yeah.
just want to go below the leaflet.
I really like it here.
Yeah. Yeah,
Do you
posterior is
want me
already
to
on.
get a better
Yeah.
picture? Yeah.
Lateral is on. So
Remember-
septal, we just have to watch for septal.
Depth is always an issue because
Yeah.
you don't have any
That's right.
RV space, right? So
Do you want me to rebuild, or are you happy with this image?
No, we haven't done a flip yet. We're just exposing the anchors. You
Yeah.
can see on fluoroscopy. So
let's check on 45, see how it looks first.
Yep.
Okay.
Lateral is on.
You
Septal
see
is coming
everything
on.
looks on here to
P&A
me.
looks good. L is on. Yeah, we just have to watch the septal.
Yep.
Here.
Is septal pinned down, or can you see it?
I can rebuild my image. I
Yeah,
think it
just
may
rebuild
be.
quickly
Would you
because
mind?
remember all the leaflets are long. This is the advantage of having a primary pathology, not a secondary pathology which is retracted. That's more dangerous. So once your leaflets are cupped, then you should be okay. And it's a small valve, it's not a big valve. So 52, 56, you have to wait for the valve to expand more actually to be able to capture because there are existing gaps. That's a reason why these patients are having TTVR and not T-tier. So you have to keep that in mind. And so you have to ask the echo imager confidently to make sure all the anchors are engaged, at least captured, ready.
Septal looks good to me, Lucy.
Okay.
Actually, all four look okay.
Okay, you're at your home. This is a much clearer
I
picture.
don't want to lose
So
sight.
I agree. So you can really nicely see A and P here.
Yeah.
And then
And
this
S
is
and
your
L.
lateral, and then this is your septal leaflet. And my blue plane is on the actual anchors themselves. You can see the anchors and short axis down in the blue box.
Excellent.
Okay.
Okay, let's go.
So we'll go for the flip. I will add just a little bit of depth here. Just, yeah, that's it. So we're going for the flip. Looks good. Agree, Lucy?
Yes, Sahil looks good. Yep.
Looks good.
I'm just watching your depth. Yeah.
Okay.
So while Sahil is doing this, I actually gain some depth and I pull back the nose cone to shed some height as well to gain some depth.
Looks really
so,
good.
So we're just doing both at the same time. So
So we
you can see an
check
echo
now.
very nicely.
Yep.
Do a
Looks
partial
good.
flip here. Let's check. So if we want to correct something, we can.
Looks good. Septal's a little
Want
higher.
to do a quick spin?
Yeah.
Sure,
Yeah,
I can
let's
do
do
a
that.
spin.
So a spin
So-
is where you go in a clock face fashion, make sure all the anchors are engaged. Now, sometimes you may have at the commissures the anchors that are not engaged. So you don't want to have two anchors that are not engaging the leaflets. So one is okay. If you miss one, that's fine, but you don't want two back-to-back anchors missing. So we'll do a quick spin in a clock face, and then Lucy will tell us how it looks. Go ahead, Lucy.
Thank you, Sahil. So I'm going to spin on blue. So I'm going to move my cursors on blue, and your eyes are going to be here on the green box on the right side to see the leaflet insert up and over into that anchor arm. So there's 9 anchors, so I'm going to move this 9 times. So I'm starting here at 5 o'clock, and it looks like the leaflet is engaged or up and over. And I'm going to rotate it. Let me just fix it a little bit. There we go. So I'm at 7 o'clock here. That's clearly up and over there. Green box right side is what you're looking at. So this is at 8 o'clock here, green box right side up and over. That's engaged. This is 11 o'clock. Not as clear at 11. Sorry, let me get on the actual anchor. There it is. I think that's engaged. And then 12 o'clock, getting some shadowing there. That may be the commissure. This is 1 o'clock. And 3 o'clock. Let me fix it. 3 o'clock is engaged. And then 4 here is engaged, and 5. So I think they're all in.
Yeah.
The one that's a little bit
I'm going to
blurry
add a little more depth
is new.
and then
Yep.
go for a full flip.
Yep. Go ahead.
Agree?
Yes, I'll go ahead.
Add a little more depth if you can. Good.
Looking good. So what's Sahil meant by gaining depth is that you want the anchor feet when it does the flip to stay at the annular level and not higher, because it can also have a risk of atrial migration too
That's
if you're
a
not
full
careful. And also you don't want to be too ventricular, then you lose capture. Now, having said that, remember this case of primary TR, we are very confident that the leaflet would have been captured already by now. If not, then we are in deep trouble. So that's why it's very important to
Beautiful.
rapid decision making is very key. I know when you first start this procedure, you take a lot of time, but remember the anatomy and dynamics change. So it's very important.
I just did another flip or spin, and it was good.
I think if this is good, then
So-
I think we go for atrial expansion then.
Go ahead,
Agree?
Sahil.
Okay.
Yep.
Septal still looks okay.
Yep. We could check
It's a little
it.
bit atrial. Yeah, kind of a little bit.
Okay.
good,
Yeah,
good.
looks good.
Good,
Yeah,
good,
I
good.
agree. Now it looks better to me.
Good, good, good.
Great.
We could do another quick spin.
Okay, going for the atrial. Okay, looks good. Okay to go for final release?
Yeah, go.
Ventricular release?
Lucy?
Yes, Sahil looks good on my end. It didn't move at all. So
Okay, so going
yep,
for
still
ventricular
should
release.
be good. Looks very stable to
So
me.
my nose cone is flexed out. I don't have any more room to pull back. Yeah, okay, I'm in. Looking good. Good.
Beautiful.
All right.
Okay.
One
Oh,
second.
let's wait. Let's wait. I like him.
Okay,
Okay,
nose
those
cone
two
is-
look center, guys.
Nose cone is central.
Good.
Stay there.
I put the nose cone already. You go. Now remember, there's a lot of tight turns, so we have to. Yep.
Okay.
Go ahead.
Yeah,
Yeah.
I'll pull back the system. Okay, Lucy, you can keep talking while we take the system out. So
Yep. So
we're
we're
going
just
to undo
following.
all that we did here.
I'm just following the nose cone on NPR to make sure that stays central, so we don't inadvertently
Very tricky.
injure
This
or
part is a
dislodge.
little tricky here. Go ahead, keep talking.
Yep. So you're almost
Yeah, yeah.
out.
Push the wire.
Yeah. There you go.
Good.
1 second.
Actually.
Very good.
All right.
Wow.
Yeah.
So we have few questions from the audience now that the stress is out. First,
Yeah.
what is the
There is
sheet
no stress.
size? We already talked about it, but remain as the sheet size
28. What is the sheet?
28.
28,
28.
and
Yeah.
any contraindication for TTVR?
Well, I mean, one of the big contraindication is very large
said that.
coaptation gap.
Yeah, the annular anatomy has to fit.
And
What-
anatomy is the
and anticoagulation. Those are the two.
Anticoagulation.
So one of the biggest thing which is excluded on the screening is on the CT, the annular dilatation. So if the anatomy has to be suitable,
swap over.
many times we bring the patient to the unit, give diuresis,
24 co-
let the annular
22 co-
shrink, and then get patient re-randomized or reassessed. So annular size is the biggest contraindication. I'm sure they will come with a bigger device, or other companies are coming with the bigger devices, and ask the point on that. Second
Very
is
good.
absolute, those who cannot take anticoagulation. So that is against. So those are the two important things. And third thing, you say that if patient cannot tolerate pacemaker for whatever reason. So because pacemaker rate is 18-20%. So that is one of them. And these cases will, if they are appropriate, you go to the second device, and that is the TTR. So TTR will be less gap. Even RV dysfunction will be okay. No need for anticoagulation. And of course, the size is a little different for the TTR. Still makes sense that it cannot be a very dilated right ventricle annulus very large.
In addition to your comments, is any other anatomical issue that should be concerned before the procedure?
Yes. So the biggest issue is the size of the annulus, right?
Yes.
So if you're out of range for the annulus, which most of these TR patients are, they are pretty big annuli because of secondary dilatation. It's the most common cause of TR. So sizing is one problem. Lack of leaflets. You need leaflets to anchor. So patients with carcinoid, patients with disease leaflets, prior endocarditis, it makes it very challenging because this is a leaflet anchoring device. So anatomically, yes, size of the annulus, the leaflets, and then what you just saw in this case, delivery of the system can be very hard if you have a massive IVC offset or if you have a huge RA with a very small RV. So those are some of the challenges that you can come across.
Thank you for coming on the endocarditis, which was another question. And finally, can this device be recaptured?
No. Once the anchors are exposed, it is not recapturable. No.
Okay, very good.
But you saw it. I mean, once everything was set, took them about 12 minutes to implant it, and now they are ready to take the sheath out, or what?
Yeah, we need to pre-close this close the device because it is a 28-French system. So we do put one plug glide to close the vein.
Gilbert, my question to you again is the same thing. You had CT scan before.
Yeah.
Could you have then, predicted beforehand that you have to go right side, left side,
we
and your
discussed
trajectory?
this. Yeah, no, as I mentioned before, the RV changes, right? It's very compliant. So even though the CT
He was
shows
talking about IVC.
there are
the issue
two
here was the
factors. There are
IVC.
two factors. So he was talking on one of them, and he can expand on this what this offset means. I'm referring more to the runway. You need to have enough runway. We learned from tricuspid tear in the triluminate trial that you can get more runway, and you can actually get better angle with a left groin access because it's away from the right side.
I think what he's talking offset runway is
no,
the
but
same thing.
smaller RV has a shorter distance, and that's what we have the issue here is, and you actually can see the wire, Lucy on echo, show that the stiff wire keeps going back to the inferior wall, and you actually you don't have as much runway, and so we recognize that, and that's why we switch to the left, because last thing you want is once the anchor is exposed, you're committed. You cannot go back.
I think Dr. Kinney has a very good point.
Yeah.
She's like, does CT predict? So CT is reviewed by two people. One, Gilbert and I review the CTs that we do, and then Edwards does a final reporting, and they tell us what, they suggest whether you should use right or left. So some of these challenges arise because sometimes you prehab these patients a lot and then changes the size of the cardiac structure. So what may not have been predicted on CT, you encounter those challenges in the cases itself. So just leave it, please.
How many times have you switched?
Twice.
Twice.
Yeah.
Second time. And
Second time,
what about how many cases so far?
Around 60 cases.
Yeah, about
60 cases.
65,
Wow.
60, 65 cases we are done.
So it's about 8%.
Remember when you are
or
doing a
so.
mitral, right? When you're doing your mitral Apollo, you are so clear with your anatomy. Can this be placed, not be placed?
But they also had
LVOT.
no. They also had
So why-
switch before. They also had switch
They've
before.
had switches,
in
and
the
also-
trial. They also had to switch because they don't have enough clearance to go with septum and also the annulus.
Also, trial cases, remember, they're very carefully selected. So you submit 50 cases, 2 or 3 get approved.
Yeah.
So they're very, sort of type A
My
cases.
thing is very simple. Maybe you got to have an algorithm to understand. IVC, RV,
Yes.
RA height, yeah,
all
RA height.
this
Yeah,
tension,
RA height,
so
RV,
that, these things are
point.
predicted
Any other
beforehand.
question? Yep,
Yes,
of course. And any other question?
Yeah, what is the antithrombotic or anticoagulation here?
Anticoagulation patient already on apixaban will continue the same.
yeah.
Question
Apixaban.
is, in the past actually they were adding the clopidogrel for a few months, but that was
No.
caused more bleeding, so
Yes.
it has been taken off.
Yeah, bleeding was one of the primary endpoint. That was a problem with
A few years
replacement.
ago, when they started, they're giving both anticoagulation and antiplatelet therapy, and we learned once you give anticoagulation for these valves, you do not need antiplatelet therapy. And that's why in the beginning, in the Evoque, when implantation, we are doing double, but now with the single bleeding on single
Are we done?
oral anticoagulation only. Yeah, let's go to the slide presentation now.
Your
Yeah, what
questions,
else?
Dr.
Yeah.
Sharma.
Yeah. Okay, let's keep going now. So let's come back to our slide take-home message. So basically, what we learned is here. First point first point, the transcatheter management of the severe TR is on rise, largely due to two positive randomized trials with the TTR and TTVR. Ongoing FDA mandated post-market study will tell us which device fits well in which situation. Then decision to do TTVR or TTVR is based on the multiple well described, which I mentioned, ability to
Protamine given?
to tolerate NOAC and catheter-induced electrical dysfunction. Although TTVR, very important, listen to this now. Although TTVR is an effective and relatively safe strategy, it is associated with higher bleeding and higher pacemaker rate. TTR is very safe but limited with high residual TR. That's it. That basically is the sense of this tricuspid field, as long as we know it. So our goal is to eliminate tricuspid regurgitation, then it has to be TTVR. Our goal is just to reduce that tricuspid regurgitation and don't worry about the pacemaker. The pacemaker need is very low, then you go with the TTR. Then randomized trial of the two devices shows sustained improvement in various quality of life parameters and reduction in heart failure admission with some mortality up to 2 years. It's possible that long-term may show further improvement with these devices in terms of survival. Then early US real-world experience with the TTVR confirmed its safety and effectiveness in high-risk patients with severe TR. 30-day real-world data are consistent with the randomized clinical trial of the Transcend 2 of the near-complete eliminating TR, acceptable safety, improvement in health status in this older comorbid population. Rates of bleeding and catheter-induced electrical dysfunction device is lower than randomized clinical trial. So clearly, in the real life, we have a lower complication because we learned from it. And lastly, careful case selection, pre-procedure stabilization, and detailed planning, as mentioned earlier, are very important. Let's go to our 3 questions, and I want to emphasize once again the contribution of the broad med AV into our live relays has been tremendous. They are our partner for so many years, and I'll encourage everyone to use them. Very, I would say, friendly team and always helpful. So 3 questions. Following are the imaging, clinical, and procedural factors which will favor TTVR over TTR, except, so which one is not in favor of TTVR? No or minimal leaflet teething, large coaptation gap, need for near elimination of TR, and catheter-induced electrical dysfunction related TR. Answer is A. You need leaflet teething. You need a little bit of the leaflets. Second, following statement is true about the results of the TRISCEND trial 2 at 2 years comparing Evoque versus control. Higher bleeding rate with the TTVR, similar reduction in TR severity between 2 groups, higher incidence of permanent pacemaker implantation with the TTVR, and significant reduction in mortality and heart failure hospitalization in TTVR. Clearly, there was a significant reduction in TR in the active group, not in the control group. Lastly, the third question, following statement is true. Only one answer is true about the results of the real world outcome of TTVR from TBT registry versus randomized trial at 30 days. Higher bleeding rates in the real world TTVR, similar reduction in TR severity in the real world TTVR, higher incidence of new pacemaker implantation in real world TTVR, and lower improvement in health status in real world TTVR. And answer there is B, that similar reduction in the TR severity in the real world TTVR, otherwise lower bleeding, lower pacemaker, and similar improvement in the health status which we saw. So with that note, I complete my presentation, and just to emphasize that even the device took 8-10 years to get finally trial, but once came to the limelight or approved clinically by the proper education, we were able to get the results much better than what was in the randomized trial. So this is what emphasis of the continuous education and teaching of these devices, which company mandates that everybody has to go through those courses before they are allowed to use them independently.
So thank you so much for the team, an impressive case. Thank you for our audience for joining us today. Remember, this case is going to be available as soon as this afternoon for your review at cclivecases.org in the section of structural. Our cases are relayed in vivo on the second Tuesday of every month. The next one will be on June 9 at 9 a.m. I'll see you then. Thank you so much.